everyone, welcome to my channel. In this video, we are going to see clinical anatomy of lower limb. Now as you are studying lower limb, you first do the hard part and then move on to the soft part. So let's see the clinical anatomy of the bones first. So first one is medico-legal significance of ossification center at the lower end of femur. The secondary center at the lower end of femur is unique in the sense that it appears during birth or just before the birth, that is at 9th month of intrauterine life. Hence, it is of medico-legal importance because its appearance in radiograph indicates that newborn baby found dead was full term and viable. So here is this picture. Can you see the arrow here? Yes, this small part shows the secondary center appearance, and of course the time of fusion is 20 years of age later on. Moving on to the next part, that is patella. Fracture of patella and abnormal ossification of patella. Now a direct blow on the patella fractures it into 2 or more pieces, and a sudden and forceful contraction of quadriceps femoris causes a transverse fracture of the patella. The patella, being a sesamoid bone, is devoid of the periosteum. Hence, when fractured, bony union does not take place. Now, this is the picture of patella. Can you see these parts? Yes, this is the fractured patella, right side patella. Next is abnormal ossification of patella. Now, the patella ossifies from several centers, which appears during 3 to 6 years and fuse quickly to form a single center. This is what is happening normally, and the ossification of patella is completed at puberty. Abnormal ossification centers in patella may form 2 or 3 separate pieces of patella called bipartite or tripartite patella. Now, this condition should be differentiated with the fracture of the patella. This is done by seeing the edges. If they have smooth margins, then this will be abnormal ossification. If they have rough or cracked margins, then it will be fracture. Now, in this abnormal ossification diagram, you can see this bigger one and these 2 small ones. So, this is a tripartite patella. Next is the tibia. Osteomyelitis of the upper end of tibia. The upper end of tibia is the commonest site of acute osteomyelitis, but the knee joint remains unaffected because the capsule of the knee joint is attached near to the margins of the articular surfaces proximal to the epiphyseal line. Now you can see this here. This is your osteomyelitis radiograph. Next is fracture of tibia. The tibia is commonly fractured at the junction of upper 2/3 and lower 1/3 of its shaft. This is because the tibial shaft is narrowest at this junction. The lower 1/3 of the tibial shaft is bare area, that is, it is devoid of any muscular attachments and has low blood supply. For this reason, the fractures in the lower 1/3 of the shaft of tibia show delayed union or non-union. So in this diagram, you can see at the junction there's this fracture. Now we are done with the hard parts. Let's move on to the soft part. The first thing we will be studying is the clinical importance of fascia lata, or regarding anything concerning fascia lata. Now the fascia lata is attached to the undersurface of the inguinal ligament. When the thigh is extended, it pulls the abdominal wall downwards and makes it tense. Therefore, in order to relax the abdomen, for palpation of abdominal contents in clinical examination of abdomen, the patient is asked to draw the legs up to overcome the pull of the fascia lata on the abdominal wall. So you can see the position for the clinical examination of abdomen. The leg is flexed at the hip joint so that the abdominal wall is relaxed and there could be palpation of abdominal contents. Next, we are going to see an important clinical anatomy in the part of femoral triangle, that is femoral hernia. The protrusion of abdominal contents a loop of intestine through the femoral canal is called the femoral hernia. The femoral hernia presents as a globular swelling in groin inferolateral to the pubic tubercle below the inguinal ligament. So in the picture you can see this. Yes, this is femoral hernia. Now the femoral ring is the site of potential weakness of the groin when the femoral ring is enlarged due to the abdominal distension with weakness of abdominal muscles. For example, in pregnancy. The coverings of femoral hernia from superficial to deep, these are skin, superficial fascia, cribriform fascia, fatty contents of femoral canal, femoral septum and peritoneum. Now let's see the course of the femoral hernia or hernial sac. It is very typical. First, it passes down from the femoral canal. This is the femoral sheath. So it passes down from the femoral canal. Then it moves forwards towards the saphenous opening, bulging forwards through cribriform fascia. So this is the cribriform fascia guarding the saphenous opening. So this, let's say a loop of intestine or any abdominal content bulges from this forward. And then finally it moves upwards along with superficial epigastric vessels in the superficial fascia of the thigh. The femoral hernia is more common in females because the femoral ring is larger due to greater width of the pelvis. Moving ahead, we have adductor canal significance. The femoral artery is exposed and ligated in the adductor canal during surgery for aneurysm of the popliteal artery. So you can see here in the picture, this is popliteal aneurysm. What is aneurysm? It is a ballooned or weakened area of the artery. So this popliteal aneurysm is present in popliteal fossa. But why do we ligate the femoral artery in the adductor canal? This is because the artery at this side is healthy and it does not tear when tied, which may occur if the artery is tied in the popliteal fossa immediately above the popliteal aneurysm. Now this process of ligation of femoral artery in this surgery was first performed by a famous surgeon, Dr. John Hunter, and the adductor canal was named after his name as Hunter's Canal. As we are discussing popliteal aneurysm, let's see about it. The popliteal artery is more prone to aneurysm than any other artery in the body. Clinically, popliteal aneurysm presents as a pulsatile midline swelling in the popliteal fossa. Next is femoral artery and vein. Femoral artery is quite superficial in femoral triangle and it is preferred for cannulation and injecting dyes to perform procedures like angiography. It is also preferred vessel for performing the coronary angiography and angioplasty. Femoral vein is preferred vein for intravenous infusions in infants and children and in patients with peripheral circulatory failure. Now we have done the femoral part or the front of the thigh part, and now we will move to the back of the thigh, actually the gluteal region first. Now in gluteal region, an important clinical correlation is with the Trendelengerg's sign. Now acting from below, both gluteus medius and minimus prevent the unsupported side of the pelvis from sagging before walking or during walking and thus maintain the horizontal level of the pelvis provided the hip joint and the neck shaft angle of the femur are normal. So here in this diagram you can see this is gluteus medius and minimus. If this gluteus medius or minimus contracts, this will pull this side downwards and hence will pull the opposite side upwards, keeping the horizontal level. When the gluteus medius and minimus of one side are paralyzed due to injury of the superior gluteal nerve, the pelvis sags on the healthy side if that foot is off the ground. Now superior gluteal nerve is the nerve that supplies this gluteus medius and minimus. If there is injury to this, the gluteal medius and minimus will get paralyzed. As it is paralyzed, this cannot contract and cannot pull the pelvis on one side, and hence this pull of the pelvis upwards on the opposite side will be lost, and the pelvis will sag on the healthy side or the opposite side of the paralyzed gluteus medius when the foot is off the ground. As a result, the person walks with a lurching gait. So when there is paralysis of gluteus medius and minimus on one side and the pelvis sags on the other side, this is lurching gait. If there is paralysis of gluteus medius and minimus on the both sides, then that is waddling gait. And this is clinically known as Trendelengerg's sign. Another clinical part in gluteal region is intramuscular injection in gluteal region. The gluteal region is one of the most common sites of intramuscular injection of the drugs. It is given in the upper and outer quadrant of gluteal region in the gluteal medius muscle. So here, this is the safe area in the gluteus medius. If given randomly in the lower part, it may damage the sciatic nerve. Therefore, it is safe when it is given in the upper lateral quadrant of the gluteal region. Then there is piriformis syndrome. You all know that piriformis muscle is the key muscle in gluteal region. Now, this piriformis syndrome is a clinical condition characterized by pain in buttock due to compression of the sciatic nerve by the piriformis. It commonly occurs in sports that require excessive use of gluteal muscles. Example, ice skaters, cyclists, etc., causing hypertrophy or spasm of piriformis. Now, sciatic nerve supplies back of thigh and the entire leg below that. So, when there is the compression of sciatic nerve, there is loss of function of the muscles innervated by the nerve. Now we will move to the back of thigh. Clinical significance of hamstring muscles or muscles in the back of thigh. If hamstring muscles are paralyzed, the patient tends to fall forward because the gluteus maximus muscle cannot maintain the necessary tone to stand upright. In ancient times, the soldiers used to slash the back of the knees of the horses of their opponents in order to cut the tendons of the hamstring muscles to bring the horse and its rider down. They also used to cut the hamstring tendons of the soldiers so that they could not run, and this was termed as hamstringing the enemy. Now coming to the clinical part of popliteal fossa. We have already seen popliteal aneurysm in the clinical significance of adductor canal. Now we will see the Baker's cyst. Baker's cyst is a cystic swelling which occurs in the popliteal fossa due to inflammation of synovial bursa underneath the tendon of semimembranosus or protrusion of the synovial membrane of the cavity of the knee joint through the fibrous capsule of the joint. So you can see this is the cyst in the popliteal fossa behind the knee, and here there is discomfort. Next is the clinical part of the hip joint. First is the Weaver's bottom. The subgluteal bursa between the gluteus maximus and ischial tuberosity is frequently inflamed and enlarged in people whose profession requires long periods of sitting. For example, Weaver's, leading to clinical condition called Weaver's bottom. Now this can happen in us also because nowadays most of the students, because of lockdown and all, are sitting at home, sitting at one place and putting a pressure on a wrong side, not sitting upright and putting a pressure on this bursa, and hence there is the chances of Weaver's bottom. Now we are doing dislocation of the hip joint. There are two types, congenital and acquired. The congenital dislocation of hip joint is more common than any other joint in the body. It occurs due to two reasons. First, the joint capsule is loose at the birth, and second, there is hypoplasia of the acetabulum and femoral head. In this condition, the head of the femur slips upwards in the gluteal region because the upper margin of the acetabulum is developmentally deficient. Clinically, the congenital dislocation presents as, or dysplasia of the hip joint is presented as, inability of the newborn to abduct the thigh. Affected limb is shorter in length and externally rotated. Asymmetry of the skin folds of the thighs, and there is lurching gait with positive Trendelengerg's sign. Then there is acquired dislocation. Now, acquired dislocation of hip joint is uncommon because this joint is very strong and stable. However, it may occur during an automobile accident when the hip joint is flexed, abducted, and medially rotated from the usual position of the lower limb when one is riding in a car. Now, in this position, the joint is unstable because femoral head is covered posteriorly by a joint capsule and not by the bone. So, during head-on collision, the knee strikes the dashboard and dislocates the hip joint. The head of the femur is forced out of the acetabulum by tearing the capsule posterior-inferiorly and lies in the lateral surface of ilium. So here in this radiograph X-ray, you can see this femur outside the acetabulum. This is the healthy side, this is the dislocated side. And here you can see the femur is out of the acetabulum. Now this causes the shortening and medial rotation of the affected limb. Now dislocation of the hip may be posterior, anterior or central. Posterior is most common, anterior is less common and central is least. And in posterior dislocation, the sciatic nerve is injured. Then let's see the other clinical anatomy of the hip joint. One is Perthes disease or pseudocoxalgia. It is a clinical condition characterized by destruction and flattening of the head of the femur with an increased joint space in the radiograph. So you can see there is the bone death or destruction, and then there is a blackish line appearance in the X-ray at this point. Then there is coxa vera and valga. Then the normal neck shaft angle is about 120 to 125 degree in adults, and in children it is 160 degrees. If the neck shaft angle of the femur is reduced, it is coxa vera. Like here, it is reduced to 105. It is coxa vera. Coxa vera occurs when there is fracture of neck of femur or there is Perthes disease. If the angle is increased, then it is coxa valga. There is increase in the angle. So 125, say it is increased to 140. This coxa valga occurs when there is, let's say, congenital dislocation of the hip joint. Now this may result from Perthes disease softening the neck due to rickets. Still other clinical anatomy of hip joint will include osteoarthritis and referred pain of the hip joint. Now referred pain, the diseases of hip joint such as TB, the pain is referred to the knee joint because of the common nerve supply of these two joints. Moving ahead is to the fracture of neck of femur. Now unfortunately it is referred as fractured hip, implying that the hip bone is broken, but that's not correct. These fractures are usually common in individuals of more than 60 years of age especially in females because their femoral necks become weak and brittle due to osteoporosis after menopause. Now there are types of femoral fractures. One is subcapital, then there is cervical or also called as mid-cervical, then basal or basicervical, and there is pretrochanteric or intertrochanteric. Subcapital is near the head, mid-cervical is in the middle of the neck, basicervical or basal is near the trochanters, and pretrochanteric or intertrochanteric is just distal to two trochanters, joining them together. Now subcapital, mid-cervical and basicervical are intracapsular fractures, whereas pretrochanteric or intertrochanteric is extracapsular fracture. Apart from the neck, there is this another fracture in the shaft, which is subtrochanteric fracture, that is also extracapsular. Now the retinacular vessels derived from the medial circumflex femoral artery supply most of the blood to the head and the neck of the femur. Retinacular vessels. A pretrochanteric fracture does not damage the retinacular vessels. Hence, a vascular bone necrosis of head of femur does not occur. However, in damage in intracapsular fracture, these retinacular vessels are damaged, and this leads to aseptic bone necrosis of the head of the femur. The fracture of neck of the femur often occurs due to indirect violence of the trivial nature. The person falls down and cannot get up. The affected limb is much shortened and rotated laterally. The diagnosis is generally confirmed by X-ray by observing two lines. One is Shenton's and another is Shoemaker. Now in this picture you can see this yellow line, that is the Shenton's line. It is represented by a continuous curved line from the upper border of the obturator foramen and lower margin of the neck of the femur. This curve is disrupted in the fracture of femur of the neck of the femur or dislocation of the hip joint. So you can see here, this is the fractured side and this is the healthy side, where there is continuous Shenton's line, and in the fractured side the line is not continuous or the curve is disrupted. Shoemaker's line. Now this is the diagram of Shoemaker's line. It is a straight line that extends from the tip of the greater trochanter to the anterior superior iliac spine, and then it continues upwards over the anterior abdominal wall to reach the umbilicus. Now let's say there is a fracture of the neck of the femur. So the greater trochanter will be elevated, and if this greater trochanter is elevated, then the line now will pass below the umbilicus. This is how you diagnose the fracture of neck. So that's it for this video. Next part of this video is coming soon. So stay tuned, like and share this video and subscribe to my channel. Thank you.